Hello, welcome everyone for joining this afternoon to our panel on replicable, and I'm only going to say that word, models of how technology can support scalable mental health interventions in lower middle income countries primarily. My name is Lauren Magoon, and I work on the research and data team at Dimagi. Dimagi, for those of you who may not know, is a social enterprise and a technology company. And we have a vision of a world where all people have the frontline services they need to thrive, which most definitely includes health services and in particular mental health services. So to work towards that vision that everyone can get those frontline services, we build digital tools for frontline workers and frontline worker programs and beyond to amplify their efforts, improve impact, and allow for greater scalability of those programs. We think this is particularly helpful for mental health and mental health care, as there are a number of evidence-based scalable interventions that exist right now that really have high potential to scale globally and in bigger numbers in order to impact the huge treatment gap we see in mental health care. Global health, is full of a number of global health issues and problems and diseases that have big treatment gaps, but mental health is particularly acute. In many countries, up to 90% of people are receiving no care for common mental disorders. And globally, I believe the number is something like 75%, inclusive of all lower middle income countries who receive no care for their common mental disorders. And even in the US where I sit, very high income country, there's huge gaps in care, delays to services, and particularly in rural areas, a lack of specialists. So today I have three amazing expert panelists here today to talk about scalable mental health treatments for common mental disorders like depression, anxiety, PTSD, and the like that work with non-specialists. So we don't need psychiatrists or psychologists to deliver the care. We can use frontline workers. And by that, I mean a variety of frontline workers. It could be a community health worker, a lay counselor, a peer, somebody working social services, or a faith healer. Pretty much anyone with the dedication and interest could go through a training and deliver a structured, manualized approach to addressing mental health care. These are typically 6 to 8 sessions, though depending on the program out there, could be as little as 1 or longer than that. And these programs basically are talk therapies. Cognitive behavioral therapies or types of cognitive behavioral therapy that have been, as I say, manualized, protocolized, so that they can be delivered by a variety of people. The World Health Organization has a number of these models. Our panelists have their own models. Groups like Friendship Bench or Sangath in India have models. And so what we're talking about today is how can technology help these sorts of programs that are frontline worker driven grow, scale, and still deliver outcomes in program level outcomes. We are mainly talking about how tech can amplify these frontline worker programs as opposed to direct to consumer or direct to client tech, which has its own potential for scale and outcomes. But that's a whole nother topic for a whole nother day, which I hope I'll be able to host a panel on that at some point. But today we'll be doing the frontline worker ones. So yeah, I think that's my introduction. So I'm going to ask each of our wonderful panelists to introduce themselves very briefly, where they work, the basic program model or models they're going to be talking about, and their role with the organization, and actually where you sit in the world. I already implied, that I'm in the United States, but we are not all there today. So I will kick off with Pavel. Can you go ahead and go first? Introduce yourself quickly.
Happy to. Hello, everybody. Thank you. Thank you for having us. My name is Pavel. I'm actually calling from the United States as well, although not as close to Lauren. I'm in a state called Colorado, sitting in Denver, although our work is in Uganda. Our model is a stepped care model, which I'll kind of delve a little bit deeper as the questions come across. But our whole kind of ethos and what we're really focused upon is how do we make mental health a routine part of general health? And what that kind of looks on a more practical level is that we work within the health infrastructure, existing health facilities, and upskill, build capacity of clinicians, midwives, nurses. So as they're providing primary care services, they're also able to provide mental health services to kind of provide this more holistic or total care of health.
Great, thanks. And good to see you, Ellie. Can you go ahead and tell us about your role at StrongMinds?
Good day, everyone. I'm Eli Atfumoza, and I'm the research director at StrongMinds. StrongMinds is mental health organization at the moment focusing on African continent, and we work primarily in Uganda and Zambia, and with some footprints in Kenya, Nigeria, and Ethiopia too. We started about 11 years ago, and the main objective is to implement a scalable intervention to depression in resource-limited settings. And we've been doing that using interpersonal group therapy, starting with a 16-week model, which we had in about 2003. And we have gradually reduced it and kept tweaking it over years until of recent when we have scaled it down to about 6 weeks. All this based on evidence, but the whole idea is to be able to implement or develop models that can confront the epidemic of depression in a scalable way. Initially, we studied about 350 USD per patient in terms of the cost. And we had to go scaling it down until recent when we have about $40 per patient treated. So the plan is to be able to decentralize, like the term we always use, the treatment of depression through lay workers in the absence of specifically or specially trained mental health specialists who are very scarce on the continent. And we work through community health workers. We have peer facilitators too, who are some of those who have gone through the therapy, have experienced a recovery, and have demonstrated interest in delivering therapy too. And we're also working through teachers as well in the school programs. So the whole idea is to be able to scale up depression therapy in a way that's cost effective in resource limited settings. Thanks a lot.
Thank you.
I'm calling it from Kampala, sure.
That's awesome. And Christy, can you give yourself a brief introduction and where you sit in this space?
Sure. Hi, everybody. My name is Christy Savetta, and I am the director of the Lubin. We're a consultancy that works with socially minded organizations like Dimagi, for instance, to help them build stronger strategies, secure funding, and scale their impact within mental health specifically. I've spent the last decade or so working as a global health fundraiser and a partnership strategist, driving investment into big, meaty global challenges like mental health care and reproductive health and digital health innovation. And my connection in mental health and kind of the sector runs deep. From my early days as a crisis counselor to co-creating digital therapeutic tools to actively supporting groups like FindMinds and StrongMinds and folks that are quite similar, for instance, who are working with non-specialist providers and frontline workers to deliver local, contextual, impactful mental health services. So I'm excited to be here today and share some of the lessons and insights from some of this aggregate experience. And I'm based in the UK.
Great. Thanks all. And I'm so excited that you were able to join us today. And I'm excited to hear what you're going to share, because I think it's going to be helpful for me in my own working with programs too. So kicking off the panel, I'm first going to address you all around finally get into the tech part, which I'm sure most of you in the audience are excited about, and how technology can help scale these programs. You both have, strong models with evidence base in your organizations, and we all know in this world that doing a program model with one clinician or one site and a few patients is one thing, and then moving from 1 to 10 or 1 to hundreds in StrongMinds' case is a big challenge. So I'd love for you guys to tell you all share a little bit about your journey from to scaling up to bigger scale, and how technology interface in that. How what did you use technology for, and also add in learnings, both challenges and successes in incorporating technology to scale up from that initial either pilot or small scale to bigger as well. And I'll address that actually first to Pavel again, and you will be first next time. I messed the order up a little bit there, but go ahead, Pavel. How have you?
I didn't know there was such a thing to mess up the order, but
maybe it's only on my list.
I think it's no mystery that FindMind uses CommCare. I don't know if it's a flagship program or project of Dimagi, but it is something that I'm maybe most intimately knowing of. Dimagi is having CommCare as the software that we use to collect our data. When we first started, technology was a bit of a speck of our kind of imagination. We started with pen and paper. I think many of us do that, loose leaf paper, just to cut down cost. And it worked temporarily because the cost was reduced, but the growing pains of having loose leaf papers that were lost, unorganized, if the wind would drift heavily on one particular day, you would misplace said papers. So the need was pretty urgent and pretty immediate that we needed to upskill or level up a bit in terms of what we were actually using to store this amazing repository of impact data coming from our beneficiaries. We then actually moved to a technology called Kobo Toolbox. And it was a free service actually developed by academics in Harvard for use in such kind of humanitarian settings that Ellie and myself and others, I think, at the conference are actually working in. And it was a useful tool. We used it for many years, but I think we've actually outgrown it. So hence, our next journey was to find something a little bit more robust, more comprehensive. And then CommCare came knocking, or we came knocking on CommCare's door. I'm not sure which one came first. And it's a newer platform for us. And we just introduced it, frankly, in July. And I think the capacity of it to provide more is exciting. The thing maybe that I'll kind of touch on a little bit here, kind of underscore, is that I am privy to how to use the technology. Our community health workers, maybe my assumption kind of baked in from the get-go, was that they were too easily interested and could take this up, and this is something that would not be difficult. And what has come to kind of my realization is that anything new that's top down transmitted to the team demands a whole heck of a lot of patience and a fair amount of growing pain of how do you use a new software. And yes, I've spent a fair amount of time kind of building the backend, looking at the backend, becoming more intimate with it. So my slate of understanding with it is drastically different than the actual team that's deploying that work. And it's been a bit of a tension in mind of like, let's go, we need to do more, deploy it quicker, provide more services. And they're slowing down a bit, and there's a bit of friction of, we want to figure out how to do this. Why is this question different than what we've accustomed to? Or where is this leading into? Or how is there are more questions that have been presented that I think, frankly, does kind of just pique our interest of we need to slow down a bit more and get it right before we speed up yet again.
Yeah, thanks. That's super helpful learnings. I think the slow and steady approach makes a lot of sense. And I think the incorporating the end user throughout the journey probably was a lesson that's shareable to others. And I think most of us in digital know that's a good idea, and we aren't always the best at doing it every time, every way, especially when we're passionate about moving fast. I certainly can relate personally to that. I am now going to move over to Ellie. Ellie, can you share a little bit about StrongMind's journey to scale and how you've used technology or not to sort of move that journey forward, and any lessons learned you'd like to share with the group?
Okay, yeah. So it's been quite a tough journey for StrongMinds as we're scaling up. So initially, while we are still doing very few numbers of treating clients, we had invested in having a team of data entry officers. I'll start with one where I was just starting in Uganda, and we had them based at districts, and they would enter data. And over time, we kept on increasing, the number of clients treated, and then the more we increase the number of clients treated, that would require more data entry officers. Then that kind of at one time became like unsustainable and unmanageable, because at the moment we're doing about between 200 to 300,000 clients for Uganda, and we have about between 100 and 200,000 for Zambia. So basically, as we kept on increasing the data entry requirements became almost unbearable and were becoming a problem, both in terms of managing the teams that were entering the data, but also in terms of costs per patient. You know, the costs basically were being increased by the cost of capturing monitoring data, which is also very important, that we have to capture this data in order to be able to do real-time, monitoring and learning and adjusting. So basically, it became a problem, and we had to figure out how exactly do we get out of this ever-growing load of data entry. So the first step, what we did was implement an SMS system. The first idea was, can we have a system that can make us not depend so much on teams which assisted in office and entering data. So, and then the next challenge we had faced was, but then we don't have reliable internet where we can send over the data and it's received in a system. So the first step was like a quick fix, whereby we had to adapt an SMS system. And this enabled teams to be able to send data via SMS in the system, in the field. And this is not just my SMS, but this is USSD based. So every facilitator who had even a feature phone was able to send their data into the system. But then at the end of the day, we realized it's very also unsustainable. First of all, also the cost of SMSs, and then also the system always goes down and things like that. And basically, we find ourselves, sometimes we have like a mix of challenges. How do we get our data into the system and facilitate real-time monitoring while also reducing cost in terms of programming? So we had the SMS system, and then it's been having issues. Then we also had to move a bit to use of spreadsheets, which also kind of had compliance issues. And then finally we had to consider doing CommCare. But even without, even aside from the internal challenges that we've been facing over time, like I mentioned earlier on, StrongMinds is expanding not just where we're having physical offices, but we're also expanding via partners. For example, we're in Kenya, we are in Nigeria, we're in Ethiopia, and in these countries we are operating. I think recently we started a partnership also in Malawi, and in these countries we're basically working either with local governments or NGOs in these countries. But also the biggest part there, the biggest challenge they're having, or the feedback they're giving us that's a problem, is most of them don't really want to print these many papers that have to be administered, during therapy. If it's government, they have their own pre-approved budgets. If it's NGOs, probably the same. They don't have the leeway to adjust quickly and be able to print all these papers that are involved in the therapy. So they've been pushing back and saying, okay, no, we actually need a system that can enable us to go paperless. So that's how we decided now to think outside the box. Can we actually get a system on board that will digitize pretty much the patient journey from the screening to all through therapy to termination? And yeah, so it's just this year bit media when we considered moving with CommCare. It's also not yet very far. We're still in the piloting process, but it's really looking okay. And at least for partners, they'll be able to administer therapy all the way from screening without even needing to print papers. So people who are being very economical, we really thought we could be able to empower them to deliver therapy without affecting their cost significantly. That's how far we've gone. Thanks.
Yeah, no, that was great. And I think there's a lot of great lessons learned for people scaling up. And I think we're remiss not to say StrongMinds is certainly maybe the biggest NGO doing this, certainly in Africa, I think, in terms of number of patients. And I think some of the things I pulled out of there was you're now scaling in multiple ways, which adds complexity to the tech processes, right? You're scaling through partners, you're scaling through governments, you're scaling through your own programs, you have multiple countries to deal with. And at some point, the cost effectiveness ratio changes, which is something I think Pavel also mentioned, right? When you're small, paper does probably make the most sense for most people. But as you get bigger, it gets much trickier to handle, and it doesn't, scale cost effectively in the same way. And the importance of, again, listening to the people using it and how they're going to use the data. Christy, do you have anything quickly to add to that topic?
Just a midline. I mean, I think from like an aggregate level, just in terms of some of the different tools, I think when we're thinking about digitizing around mental health, really, I think the two kind of big things and trends that are happening are in frontline worker facing tools and kind of client facing tools, and kind of focusing on that patient journey can be focused on the client, for instance, where you might have chatbot self-management tools, things that might supplement, for instance, the work that a frontline worker might be delivering. So you might have at-home chatbots to support with therapy practice, like Practice Pal from Dimagi, for instance, or other tools like that. Or you might have, the frontline facing tools, the frontline worker facing tools, where you're doing things like the data collection, or, providing digital job aids, for instance, on that particular frontline worker facing tool. So you don't have to, do all the printouts, if you will, or maybe using it for training or supportive supervision, or maybe even actually having a frontline worker facing tool totally focused on that frontline worker's resilience and providing them with tips and tricks. So I think there's a mountain of things that could happen within the digital space and within mental health. And I think really we're kind of only touching a small part of it here, but a really, important part and kind of a really fantastic part. But I think it's good to kind of couch it in some of that context.
Yeah, thank you for that big picture framing, Christy, right? The tech and solutions can fit in throughout the program models, especially as you scale and have the need to do so to speak. Thank you all. So my next question is sort of around quality and outcomes, particularly when we're talking about frontline worker delivered programs. Certainly from people who aren't very familiar with them will be probably especially worried about this. But I think it is, fair to say programs worry about as well, is how do we make sure these programs, especially as they scale, continue to have quality care delivered, sort of model fidelity. People are following that sort of manualized approach that you all have developed and are spreading. And how do we keep track of outcomes for both the patients and for the program level? And how is digital tools supporting that as you grow? And I also just want to point out this data often for clinical outcomes and sort of worker program outcomes often has a number of stakeholders who are interested in this, from program managers worrying about the people they're supervising to governments paying for the work or foundations paying for the work. And I know that's a whole bunch of stuff at once, but how are you all thinking about digital tools to help sort of support monitoring and measuring quality at the clinical level or patient level, as well as at the program level, I guess is a better way to put it. And you can sort of take that as you will. So for this one, I'll actually start back with Ellie and hear about how sort of StrongMinds thinks about that, especially as you are, in the research team. How are you using tech to make sure you're tracking clinical outcomes and sort of program outcomes, and how does that help or not in your day-to-day?
Okay, so what is happening basically is how we scale internally in the countries where we're working indirectly is we have a system whereby we have the lay workers, the frontline facilitators. Then we have a level of mental health coaches. We have another level of mental health supervisors, and that's usually at the district level. We really work to make sure that mental health coaches are always in touch with our facilitators. If they are new facilitators, they're taken through a thorough training. and then a period of mentorship, and also the mental health coaches, they keep on checking on them all the time, taking them through the client journey, until at one time when they think they feel they are comfortable, but still we do supervision via the mental health coaches, though we go on reducing a little bit once we sure these facilitators they're okay. And monitoring data plays a key role to really make sure that we are able to monitor the outcomes and also the therapy pretty much in real time. But from where we're coming from, we really have been, I must admit, struggling with the whole issue of real-time data collection. So to some extent, we had that lag, and for us, we could be sure that, or a little bit confident in the teams that we have deployed in the field, the mental health coaches and supervisors, and also the embedded officers that we use for partners. We feel that there is need to be a little bit more engaged in real-time monitoring, so that we're able to provide like very quick feedback just in case we notice there's a problem. And that's pretty much one of the reasons that we seek to make sure we have an improved data collection system, so that we are better at providing feedback. It's okay at the moment, or maybe fairly okay. We are a bit comfortable, but we just feel we can do better. Because if we're able to have all this data pretty much real time, then we're able to course correct in situations where we realize there's a problem. So it's an area where we're growing, and it's pretty much one that inspired us going digital in most of the activities that we're doing.
Great, that's super, super helpful. And how about you, Pavel? Same question. How are you using tech in some way to collect data or support quality outcomes and sort of managing stakeholder expectations and all that?
Sure. Ellie, I just appreciate the candor and the humility to what you spoke. Yeah. The size of StrongMinds and still kind of being thoughtful about saying, hey, we're also undergoing some challenges and some growing pains. I think that's actually encouraging. Technology is a huge thing for us. I think it offers speed and convenience and ease, accessibility. One of my favorite quotes is by Wayne Gretzky, and he says, "You skate to where the puck is going." And I think generally mental health or any field, frankly, we're skating to where that puck is. And that puck, I think, is integration of technology to support critical work that's being done on the front lines. So for us, we're trying to be kind of on the front lines of what is our cocktail of metrics that we're measuring to actually showcase impact and outcomes. And I don't think we've kind of hit the nail on the head with that, because there are maybe more universal ones that are accepted, and those are the ones that we kind of hang our hat on. And then there are certainly ones that are locally developed. At least for us, we have 5 main ones. Patient health questionnaire, which is maybe most universally known. We have the HUDAS, which looks at functional impairment. We have a suicide risk screening that kind of shows us a concrete level of risk, and then from that, what needs to be done. We offer something called Problem Management Plus, which looks at depression and anxiety, but also kind of wraps into that adversity. And with that, there's something called the Cyclops, which is a fascinating name, but it looks at the patient-defined concerns. And then last but not least, we have something that's called the HRQOL that looks at the general quality of life in hopes of actually getting down to unit economics and cost effectiveness. Now, if you could imagine us collecting 5 of these assessments without technology, I mean, that's overwhelming. It feels like nothing would ever get done. We would not have streamlined processes or analysis coming from it. So technology is essential. It's a fundamental tool for us to streamline this collection and then effectively analyze each of these metrics from each session, kind of individually, but also collectively. So all that's to say, technology tantamount to our success, but similarly to Ellie, growing pains and some work to be done in streamlining the processing and making it more efficient and better for our work.
Yeah, that's I mean, hearing you list all those is a little mind-boggling, I have to say. And it points out something to mental health care is that it's harder in some things to diagnose, right? There's not a blood test, at least as of today, that says, yes, you're depressed, no, you're not, and what level, like it might be for other things. So in mental health, there is this broad range of scales that the community uses that are some mix of self-report, some observational, and they get at sort of different aspects, as well as for people in the audience who aren't as familiar, a lot of mental health is approaches are sort of transdiagnostic and are trying to address multiple common mental disorders at once, because there's so many comorbidities between depression and anxiety, or anxiety and PTSD, or sometimes eating disorders are thrown in. I don't think either of your groups do that, but some people do. And so there's this range of things that aren't clearly defined in a way, and may even impact people different day to day on some level, that makes this tricky. And I should have asked you, Christy, to reflect before I did as the moderator. But do you have anything else to add to that, Christy? Not that I've done it for you.
You're okay. It was going to be similar. Great mind. You know, think like here. I mean, I think the only other thing, like around some of this, for those folks who might not be as familiar with the sector, you know, measuring mental health, and I think you've kind of hit the nail when you kind of talked about the cocktail of tools that you're using, is incredibly difficult, right? And as Lauren, as you were saying, you can't just take a blood test, and it's not just a single outcome. You don't get a situation where you increase antenatal care visits and a health outcome changes. And I'm not saying it's simple in reproductive health at all, but in mental health, there's so many side effects and secondary impacts that happen when you support and increase somebody's mental health. And also the definition of mental health is different per culture, per context. If you're using the PHQ-9, the depression index, to measure someone's mental health, are you actually measuring good mental health? Or are you just measuring the absence or presence of depression? So what does actual good mental health mean? And it does change per country, per culture, per context, and language changes when you talk about it. So when we think about measuring, kind of speaking to your point, Lauren, earlier about, you know, the various stakeholders, there really isn't like a common measure for a mental health program, which means that when you try to ladder up and kind of understand on a global scale, where are we as like a world in mental health, or where are we as a sector in terms of the ability to advance outcomes in mental health, it's very, very difficult to know. And there's some really cool initiatives that are ongoing and kind of happening right now in the background that are aiming to try to establish or think about how common measures could become a thing. And that, honestly, I don't know how possible that would be without technology, right? If you have a tool, if you have something like that, that enables individuals to collect so many different data points, where you can do this analysis, where you can think about it from an aggregate level to try to advance the sector, you know, I think, you know, having technology within the space is incredibly important. So having organizations using it and kind of thinking about it and using it for data collection, all that kind of stuff, and measuring impacts is important, because it kind of ladders up to this broader spectrum. So it's a bit of a high level thought, and there's a lot of privacy and security implications, which I'm sure we'll cover, but it's an interesting part of the sector, and difficult.
And Christy, I think intentionally there, teed me up for our next sort of topic here, which is sort of privacy and safety. And I think what you were just saying reflects even bigger picture as this sort of space of mental health. And I'm going to get to your question in a second, Christy. As people are using more sort of big data science and AI to analyze outcomes, to make things more prescriptive by person, or more precision treatment rules and precision treatment analysis, as well as the way our panelists are using technology now for data collection, monitoring, evaluation, and measuring, you know, things like the PHQ-9 and the like. Privacy and security is critical. I mean, which it isn't all, you know, program service delivery, and certainly in healthcare. And there are a number of sort of diseases out there that have stigma attached. But I would argue mental health is one of the, certainly not the only, but a top one, that there's severe stigma attached to people with mental health conditions in many countries, and probably most countries in context. So one of the things that I think a lot of people worry about is collecting a lot of mental health data in one place, in technology, and certainly patients are worried about who knows that I'm depressed, or who knows I'm anxious, who knows I have PTSD and the like. And certainly definitely so for people who have severe mental illness. I feel schizophrenia, bipolar, which generally are even more stigmatized. As this field of digital health folks, how do we sort of address this? And most importantly, and I'm going to ask Christy this, she's worked in this space a long time. How do we get patients and clients to understand what we are doing and why it's its risks and benefits to them? Because I think it's a tricky situation to sort of have real consent in collecting this sort of data, particularly in the space. So Christy, I'd just love you to reflect on privacy, confidentiality in the space, and how we work with clients, particularly on that, not the back end tech of how we keep things safe, but how as a program level we manage this in our clients.
Okay. All right. No, that's helpful. It's a great question. And the other kind of thing to add to it is, around that stigma piece, a lot of health areas as well bring stigma with them as well, right? And so you have, for instance, instances of HIV or TB are already dealing with a really difficult cause. And then you also have stigma associated, which causes and can change and can adjust how you feel about yourself, and self-stigma, internal stigma. That's all really cool areas of work that are ongoing right now, and figuring out how that affects your outcomes yourself. So data is important, but it is in terms of privacy and security things. I mean, I'm by no means an expert in this, but I've worked in the field for a little while, and there's kind of three things that I always like to talk about. And the first is consent, right? And it's like about genuine informed consent, to actually build trust with the clients and the people that you're working with. And what that means is like really making sure that they fully understand what's actually happening with their data. What is being collected? Why is it being collected? What happens with that information? Where is it going? And keeping in mind the variety of areas that we work in and socioeconomic contexts that we work in. If you're using words like cloud, for instance, how do you describe that to someone who might have never even used a smartphone, right? What is a cloud? And I mean, even I can't describe it. It's in the sky. It's a fluffy white thing. Like, how do you actually fully describe what that means in a way that someone can truly understand it and say, yes, I don't want my data there. I want that back, or delete it from there, and prove to me that you've done that. And giving people the power and the language to know what their rights are with their own data is super important. And so there's some really cool initiatives that are kind of out there, some companies that are focused on this, that they're thinking about using consent, or using like storytelling or folklore to kind of talk about consent and make sure people really truly understand what it means to give consent around data, using things like layered consent or audio-based consent, so that you're catering to different needs or different kind of disability sets, for instance. All of that kind of work I think is important to really make sure that someone fully understands what's happening with their data. The second thing is data minimization. So only collecting the data that you genuinely need for the program, which in mental health we've kind of established is hard, because there's loads of metrics and loads of things out there that you want to check, secondary effects, all of that kind of stuff. You want to know, if we improve this person's mental health, what's the impact on the family? Because that's important. But making sure you're collecting information that you really truly feel is necessary for the program, and not unnecessary personally identifiable information, right? So those required elements. And the third is just, Lauren, as you kind of mentioned earlier, data storage and security, right? And we won't get into it, but really it's, where does it live? Who's the best person to store it? How is it stored? Is it local infrastructure? Is it cloud infrastructure? What's safer in your context, in your area? And ensuring that your data is pseudonymized. So you're replacing all of your personal identifiers with placeholder values. So God forbid someone breaks into the back end, all they see is these placeholder values and potentially numeric values, for instance, and data, and they can't necessarily ascertain whose data is whose, if you will. But you're still able to go back and delete data if someone wants you to, because you haven't anonymized it. So it's all those kinds of little things that layer into treating data in a way that is someone's personal belonging, and making sure that you're protecting it in the way that we should, especially for individuals who are just learning about like data and privacy and all that kind of stuff themselves in that moment.
Thank you, Christy. That was a fantastic overview of a lot of those issues, much better than I could have ever explained it. So I appreciate that. Pavel, do you have anything to build off that, or anything you wanted to add to, how you engage in privacy, safety? If you have anything to say.
I'll add 2 quick points, because Christy, that was a phenomenal overview of all the key pieces to that question, and really, really insightful. Because we work within primary care, we have kind of the luxury of using that as a Trojan horse. So as opposed to singling someone out and saying you have depression or you have a disorder, typically our first interaction happens at a health facility. So they're there for something, generally speaking, that's physical. Maybe they're waiting for their labs to be done. Maybe they're actually taking their child and they're sitting idle, or something else is at play. And because the folks that we have trained, they're the ones who are providing this general health service, this primary care, they're now privy to symptoms that may also be mental health in nature or emotional in nature. So as opposed to isolating that person and saying you have depression, they're able to use the context of the backdrop of primary care. So that's been really wonderful for us to not isolate anyone. I'll say one last thing. We are very careful with the language that we use. I think in this context, in this webinar, we're talking about depression and anxiety, mental health, and mental illness. We don't necessarily go up to a community member and say, you have depression, or you are depressed, you have a disorder, you have a problem. I think generally we couch it under, again, a stress. I think stress is a very ubiquitous and a universal concept that we can all relate to: interpersonal conflicts of sorts, life happening, work. I think that all of a sudden becomes a little bit more approachable and accessible.
Yeah, those are great points. And I just want to that was a benefit of embedding mental health into primary care that I actually never put two and two together of that. And I love when people personally are embedding mental health into primary care, because it is very helpful when feasible, because then you can sort of address all of those comorbidities all at once. That said, not always feasible in all contexts, in which case we need to be getting people care, however, is feasible and acceptable in that area. But I really appreciate that. And Ellie, do you have anything else to add on data privacy or working with your clients around this topic?
So maybe just for the purposes of Strong Minds, I agree. Christy has pretty much broken down the key aspects of data protection and privacy. So for our case, I can say we have about 3 layers of assuring data privacy, right from the point of facilitating therapy sessions. The protocols include several mentions of the importance of maintaining confidentiality within the groups, so that people's issues don't end up outside the group. And we have seen that especially in the in-school projects, where it's basically like a small community. We have people who are likely to talk, share information to other people, other students. But unfortunately, we haven't seen that happen, because what we do is, when we enter school, when we enter community, we do enough sensitization. So basically, right from the start, we attempt to reduce stigma. And I think what might be contributing to that is trying to adapt the terms to the local community, to the kind of language people will understand, that won't really sound as scary. I must admit, I think if we had to tell someone mental illness in the communities, it might sound a bit scary and so much for people to worry about. So there's a lot of sensitization that we're doing prior to engagement in communities or schools. Then there is another level for the facilitators and coaches and supervisors, all those people. We have implemented policies to ensure that they have confidentiality clauses in the contracts, basically to make sure that client data is safeguarded, nobody's data is going to be out there. And then part of the protocol also, as a guide of the policy, guides how data is shared, how it's stored, not just sharing data anyhow by email or by open spreadsheets that could potentially compromise participants' information. And mainly what we're focused on is, if we must share data by email, then it's de-identified, it's anonymized, it's encrypted. So it's those 3 layers that we're trying to make sure we utilize to make sure that patients' data is secure for the purpose of maintaining confidentiality of patients' information.
That's great. And really good point about email and making sure anything in email is always confidential like that. Appreciate that. So I'm looking at time. We have about 15 minutes left. So I am hoping folks in the audience might have some questions they want to address to our group. So please, if anyone listening has any questions about anything we said or people's programs, please go ahead and put those in the chat. I'll give you a second to do so. And I have some pre-prepared questions, additional ones, if people are quiet in the audience. Maybe while we're waiting for people to speak up and copy over the questions. I actually have a question for the panelists. Did any of the panelists want to ask another panelist a question?
I have a question. I mean, I think it's similar to something that you probably have in your backlog, but I'm just kind of curious about it. We talked earlier a little bit about, frontline worker tools, but also client-facing tools. And I'd be curious to hear a little bit about your reaction around digital tools for clients who are receiving mental health services, whether it's chatbot, self-management, extra practice at home, whatever that might be. So it's kind of an open question for both of you, and Lauren, for you as well, for anyone on the panel. Any thoughts you have around kind of those client-facing tools that we do know as well are kind of becoming a little more popular, especially with AI, as we can say it and spend an hour and a half talking about it, but we don't have to dive too hard into it. So anything around that topic around client-facing tools?
I'll jump in then. And feel free, Pavel or Ellie, to let me know if there's anything else you want to add after I'm done. So yeah, thanks, Christy, for that. And this is part of the work I do sometimes at Dimagi, is thinking through how we might use AI chatbots to support clients in programs like this, or potentially as standalone treatments. We're not really doing that right now, although I do think there's a high probability, and lots of other people are working on that. But one of the things that I think is a idea, and we've been working on a bit with some folks in India, with Sangath in India, and we did an agency fund award on this, is giving clients a chatbot to support them between their sessions with their frontline workers. So for talk therapies that we're sort of talking about here, and cognitive behavioral therapies and therapeutic interventions, a lot of the hard work is done by the patient themselves, like reframing their thoughts, thinking about the world slightly different, recognizing patterns of behavior. And it's easy, particularly if you're depressed, to go to your session and then just like not do that stuff between sessions and wait to the next session, which can delay people getting better or keep them from getting better. So in a lot of these programs, they assign sort of homework between sessions or assignments or things they're supposed to be doing. They don't all do that, but many of them do. And so having a chatbot to, just give nudges, reminders, collect data for their own personal purposes. A lot of these programs use behavioral activation, which is a way of connecting behaviors to mood. So like realizing that you'll feel a little better if you go out and do a social interaction. And so keeping track of your activities and your mood in real time can be helpful for the patients. And that can connect to the frontline worker to see that data, or sometimes even not, just for the own client-facing tool. So I think that is a great potential to amplify these programs, as well as I think there'll be increasingly, and there actually are, increasingly number of people in articles and research on sort of standalone treatments and for whom they work and when, which is, I think, to me, the key question. They won't work for everyone, is my guess, but for some people, I think there is potential. Okay, so that's my 2 cents on client-facing. Great, and we actually have a question from the audience now, which I will I'll put out to the group, and whoever wants to answer, go ahead. First, they said thank you, which is very, very nice of them. But the key question, and this is a good one, we should have addressed this: how effective are these task shifting approaches with community counselors or lay people? And where do you see, or do we have data probably to talk about how tech improves effectiveness? And I think this is particularly addressed to StrongMinds, but I think if one of you or somebody can cover like how impactful frontline worker approaches are, and then whether we know tech actually helps, would be great.
I can tackle that first one, Ellie, and then maybe you can jump in a little bit on the second part. I I'm biased. I think we're all collectively biased here. I'm a firm believer here that task sharing is key. Gosh, it is vital to bridging the mental health gap. In Uganda, for context, there are just 50 psychiatrists for a country of about 50 million people. If you do the math there, you have one psychiatrist per million people. That's a drop in the bucket. You have even less psychologists. So I think it's incumbent for us to find other means to provide effective care. I'm interested to see how technology starts to play even a bigger role. If you look at artificial intelligence and kind of leveling up or leveraging more of a workforce to provide said care. But at the moment, I think our greatest asset and resource are people and peer counselors who have a zeal, a passion for their local community, an enthusiasm to give back. I've not yet found a better cadre of worker to provide said services. We've done a pseudo RCT to really kind of underscore that impact, and the numbers have come back certainly exciting and effective. When we'll continue to analyze that, so I guess maybe stay tuned for more of that. But I'm sure Strong Minds, Dimagi as well have maybe more concrete or hard numbers. But in terms of efficacy or effectiveness, high, high effectiveness in terms of task shifting.
Yeah, if I first of all, that's a great question relating to effectiveness of using lay workers. So that's definitely one question that's worth raising concerns, given that these are not trained or specialized personnel. So we've faced those questions before, and as such, as a result of that, we've been conducting annual or biannual evaluation exercises. We call them external validation. And the most recent one for 2024, the report should be almost out, which should be published, I think, on the website soon for the purposes of anyone that might want to read through. But the spirit behind is, can we validate that the data being collected or the assessments being collected by the lay workers is actually valid or would be consistent if we had to use a trained psychologist. So for the exercise for 2024, we recruited a psychologist and they did assessment for depression before therapy. They also did assessment for depression after therapy. And then we did an analysis comparing their results versus those from clients of the other facilitators that were not selected to be assessed by psychologists. And the numbers show that there is consistency in terms of, first of all, assessing whether these clients are depressed, and also at the end of therapy, assessing whether they actually have been, their depression symptoms have reduced. So this is going to be like a very interesting paper, an interesting report to read. I'm saying maybe whoever asked the question could look out for it. It's ready, should be out, published on the website in a few days or weeks. Then we also plan to implement a randomized controlled trial, and I think that's one thing that will probably give us much more credible information regarding effectiveness. So that's what's in the pipeline. We hope to get it launched come next year. As concerning how technology might facilitate that, I'll pass that question to the Dimagi team.
Great. Yeah, nothing. Oh, go ahead, Christy. Please.
I'm happy to just jump in a little bit on behalf of some of the work that we've done at Dimagi, and I know Lauren, you've done a lot of this, so I'll just kind of tee it up, and it's over to you. But in terms of some of the areas around improving, like using technology to improve effectiveness, working with non-specialist providers. I mean, some of the things that we were talking a little bit about earlier in terms of the tools and the way that that tech could be used for frontline worker facing use cases. One of them I think that's really interesting here is as a job aid and as kind of a training and or like supportive supervision tool, where you're actually utilizing the app that you have or the tool that you have to provide, additional information. So one use case, for instance, we built an application for interpersonal group therapy that we piloted with a couple of groups in Uganda a few years ago. And we worked with them to build a tool that specifically walked a frontline worker through each particular session. So what are the kind of different pieces that you want to be talking about in this session? Okay, if you need to be talking about grief, if you click on this, you kind of brings up a little indice, you can read a little bit more about it and just remind yourself some of the prompts that you probably picked up in your training. And so it's that kind of level of support for them as they kind of go through. And what we found is that, most frontline workers, after they'd kind of done a few rounds, didn't necessarily need the tools anymore, but they found them to be a helpful fallback in case something happened. And the other interesting outcome was that they also felt like having that tool themselves gave them a little more power and authority in that group, and that a lot of the folks within the group felt like they kind of respected the leader of the group a little bit more, the frontline worker a little bit more, which was an interesting kind of qualitative outcome from that. It was a small study, but I think you see that in a couple of other places as well. And then the other piece is around kind of supportive supervision. And I don't know, Lauren, if you want to talk about this. I think a lot of your work has kind of been in that area.
Yeah, so we do some work under a Grand Challenges Canada Award with University of Toronto and Daisy Singla and Vikram Patel and Sangath in India, where they are piloting using technology to help support the peer workers to make it even more scalable. And they're using session recordings where people listen to each other's sessions and then peer rate each other, and then look at those ratings over time. And they've shown in early studies that the peers can actually sort of self-supervise over time, as well as a psychologist would supervise them and rate themselves on the same scale. I'm not explaining that super clearly, but they're using technology to support this scalable peer supervision process. And there's a number of papers out on that. And just sort of big picture, most of these models are based on core cognitive behavioral therapy techniques and are adapted for local context. So those are all, evidence-based. And a number of these models are also part of World Health Organization manuals who have done numbers of RCTs on interpersonal therapy, using lay counselors, behavioral activation, using peer counselors and whatnot. So many of the NGOs, and I can't remember exactly which ones you both use, are sort of using some of that core stuff that's definitely out there in the peer-reviewed literature and under RCTs. Friendship Bench is another one. Sangath has RCTs as well. And then we're working our way through which pieces of tech really boost outcomes best as we sort of go. And that's actually a key part of my job, that we try to figure that out with other academics. And we have 1 minute left. So I'm going to just thank our panelists and thank the Global Digital Health Forum for having us. I really learned a lot, and I hope our audience did too. And with that, I think we will sign off. And Christy said, if any of you want to reach out to, certainly I'll speak on behalf of Christy and I, feel free to use our bios in the portal for the conference, and we'd be happy to chat more. And let us know if you want to talk to the others, and we'll confer with them as well. So thank you, everybody. Have a great rest of your day, and GDHF.